procedure strategy adding a weight loss medication. The title of the presentation is Combined Treatment of Overweight with Intragastric Balloon and Liraglutide at High Dose. Is it worth it? Yeah, I realize that it's not Ricardo.
Hello, I'm Dr. Carolina Hoff from Brazil, and I'm here in behalf of Ricardo. So I'm here to present our paper about combined treatment of overweight and intragastric balloon with liraglutide at high dose. Is it worth? So intragastric balloon and liraglutide single therapies are used worldwide to treat excess weight and obesity. However, by the time we published this paper, we submitted, there were no studies published yet. The idea of the balloon came with patients with a bezoar, psychiatric patients with a bezoar. So why don't we think about an artificial bezoar? So that was what happened in Tarpon Springs Conference held in Florida in 1987. So why the rules for building a perfect balloon was it had to be filled with saline fluid and has to be made with high quality silicone elastomer with a spherical smooth surface, hydropack marker, and a volume to be adjustable between 400 and 700 millimeters. So we used the Orbera balloon because it fulfills all these criteria. It's an extremely safe device proven in hundreds of studies, and it's used worldwide, including Brazil, for over a decade. The mechanisms of action of the balloon, it's because it's a space-occupying device. It induces satiety by a hormonal effect, maybe, by a neurological effect like gastric stretch receptor stimulation, and the main thing, it delays gastric emptying by working as a cork so that the food doesn't go to the duodenum very easily. And liraglutide is a GLP-1 analog. It binds and activates the GLP-1 receptor. It increases the secretion of glucose-dependent insulin by pancreatic beta cells. It reduces the glucagon secretion. It delays the gastric emptying due to gastroparesis. It reduces hunger, increases satiety, reduces body fat masses, and improves blood glucose levels. So we wanted to evaluate the efficacy and the complications of intragastric balloon therapy alone and combined with liraglutide. So our methods were, we included patients with BMI above 27, patients at a risk of baseline gastroparesis like type 2 diabetes, and patients over 60 years old were excluded. Patients were randomly divided into two groups by pulling out a yes or no folded paper inside a bag just before the balloon implantation. In group 1, they isolated balloon therapy, and in group 2, combined liraglutide and balloon therapy. Liraglutide was one dose in the morning, maximum of 3 milligrams, and the mean was 1.8 milligrams. And the balloon was 6 months permanence in both groups. So we had the data analysis, the descriptive statistic, the student t-test, the analysis of variance followed by the Tukey post-test, and a level of significance was a p-value under, was set to a p-value under 0.05. So we had 45 similar pairs of patients because they were the same sex, similar ages and BMI, randomized into group 1 and group 2, and both groups had the same composition, 32 women and 13 men, similar in mean age, 34, and similar in mean BMI of 33, almost 34. So the results, We had 17 non-completers. In group 1, just 3. 2 due to early balloon removal, 1 due to gastric ulcer, and in group 2, 14 patients. 12 due to liraglutide use interruption, 1 because she felt like she reached the ideal weight, and 1 due to gas production inside of the balloon. Here's a photograph of a gastric ulcer. Here's a gas production inside of the balloon. And here are the results. So we can see that in both groups, the initial BMI is very different from the final BMI, meaning that both treatments are very good, but as we look at the final BMI reduction in group 2, it was 7.53 compared to 6.21 in group 1. So there's a statistically difference very low and very, very important. When we look at the results in weight in group 1 and group 2, the final weight in group 1 and group 2 are very, very significant compared to the initial weight. But as we look at the results in group 2, was 21 kilograms in comparison to group 1, that is 17 kilograms. And as the same in total weight loss, we have in group 2, 21%, 22%, and in group 1, 18. Excess weight loss in percentage, 86 in group 1, 71 in group 1, 86 in group 2, and in excess weight loss, 21 kilograms in group 2, and in group 1, 17 kilograms. All those numbers were analyzed, and there were statistically significance in all those, applying all the criteria. So, intragastric balloon has the 3 mechanisms of action, and the most important is the gastric empty delay. Liraglutide does also have the same effect through different mechanisms. The combined therapy seems to potentialize this effect, promoting an even greater weight loss. Liraglutide was chosen for this study due to its relatively short half-life. Weak points of our study was the absence of a sham group, non-standardized liraglutide dose because it's due to tolerance of the patient, a non-standardized initial balloon volume because we think it is due to each patient. Strengthening points is the sample size, the randomized study, similarity between both groups, and a novel possibility of combined therapy. Both treatments are effective in promoting weight loss. Liraglutide has a little higher rate of intolerance. When tolerated, balloon combined with liraglutide promotes a higher weight loss, over 20%, compared to intragastric balloon therapy alone. Liraglutide seems to be a great adjuvant drug for the intragastric balloon therapy. And as we know, obesity is a chronic and progressive disease, so whatever we can do to sum up is worth. I'd like to thank my mentor, Ricardo, and thank you all for being here.
Thank you, Dr. Anna. Great job. There's a question.
Very nice presentation, Dr. Anna. Congratulations. It's an incredible study. And I want to know about how was the progression of the dose of the liraglutide. If you began with the dose in the maximum and you adjust according with the tolerance of the patient, or if you began it with a smaller dose, and after that you have progressive this dose. If you could explain it for us, it would be great. Thank you.
We began at 0.6, which is the minimum, and we were summed up by the level of tolerance of the patient. If the patient told us that